this office has been very helpful in partnership and developing the issue of TB in this country. So we appreciate your support and of course the ministry. I think today is an opportunity where we have some of the champions. I'm sure you know Honorable Mure and a few others who have been at this thing for a long time. And the reason why you see people like Honorable Mure, by the way, Dr. Mure also used to work here. Honorable Mure also used to work here. He was a molecular scientist, the person you'll be seeing here. So I want to say that the reason why we have TB and TB caucus is the largest support we have from Europe and others. And therefore this team comes as part of all those things, including the start of the Stop TB partnership and many other people behind the scenes that have been looking at these issues. Both TB and HIV are very well. Now we are very clear that either both of them must work together. If we don't have money.
And the Kenya TB program is one that prides itself as being very collaborative in terms of its engagement processes. And when we look at collaboration, we're talking civil society, we're talking communities affected by TB, and even at the lower levels, at the very community level, working closely with the patients themselves to make sure that treatment is actually people-centered, and at the end of the day, we're responding to the needs of the population. Secondly, the program also prides itself as being one that is very adaptive and open. We embrace change, we embrace innovation. So one of the things that has happened is over time, Kenya has prided itself as being one of those countries that whenever there are new opportunities to give patients better quality of care, whether it's diagnosis, treatment, or prevention, we quickly adopt that. And as we have seen in the recent past, starting as way back as when we were launching the pediatric formulations, I think Kenya was the first country globally to roll it out nationally. And cascading down the road, we have seen improvements in our drug-resistant TB regimen. We've seen improvements in our diagnostics, where now, apart from just gene expert, we're introducing other molecular tests like our TrueNat. We're also embracing technology. We are now trying to adopt the use of digital chest X-rays with AI software for screening and diagnosis. And at the end of the day, the main aim, and for prevention, we are also adopting the shorter treatment regimens for TB prevention. Basically saying that if there is something out there that can make the quality of care for our patients, either they're able to access diagnosis faster or better, or they're able to be treated and recover within the shortest time but with the highest quality of treatment options, then that is what we go for as a program. Additionally, we have already started initial conversations, especially around the vaccines, and it's a very interesting space for us because we know TB prevention. Treatment is one of the mainstays of TB prevention because then once we treat the persons that are potentially spreading it, then we're reducing the burden. But we're also seeing that apart from that, we need to strengthen other prevention modalities. So we have the fact that now we have expanded the population that is accessing TB prevention treatment to include not just the children, but also other household contacts who are older than 5 years. And trying to see, working with the communities to see how we can strengthen the community model of delivery of the prevention strategies. So looking at how we can visit the homes, identify the contacts, and even deliver preventive therapy right at community level. Then multi-sectoral engagement is something that the country also prides itself in doing. So apart from working with civil society and the communities, the country recently launched the multi-sectoral accountability framework, basically providing a basis to engage with other sectors, both within the ministry and outside, including the private sector. When poverty sets in, then it increases the risk of people contracting TB. Then the other advantage of collaborating with other sectors, especially the ministries, is that there are a lot of resources that you can leverage on to be able to advance the TB agenda. And a good example is recently we have what we call the music festivals. So this is a forum where the primary school children come for music recitals and competitions. And one of the things we did is we made TB a theme in those recitals. And what that is doing is, one, we're trying to break the barriers and break the ice on TB so that it becomes something that is a common message out there. But also we have seen the power of the message there, because then once they are aware, if there are any contacts within their community, they become actually our agents of change at that level.
Shall I go first? That was really interesting. Couple of questions for you. Yesterday we heard that international funding, that 50% goes to HIV and then it's less to TB and malaria. You mentioned about the link between TB and malnutrition, but you haven't talked about TB and HIV, so perhaps you could touch on that and see how that can be leveraged and to maximise the support from at your level and also from civil society. And one of the more general questions, you talked a lot about a lot of challenges, but what is your major challenge that you have out of all the ones that you talked about? What keeps you up at night is probably the best.
The TB and HIV. Now we have had very good collaboration with our sister program, that's the HIV program, and the level of collaboration comes all the way from diagnosis, treatment and prevention. So starting with screening and diagnosis, one of the things that we have effectively been able to accomplish as the two programs is to make sure that all clients that come in with HIV, during every visit, for example, they're screened for TB. And those that do not have any symptoms are actually initiated on TB preventive therapy. And we've been able to achieve over 90% of TB preventive therapy uptake amongst the people living with HIV and AIDS. And for those that are found to have TB, we have expanded the coverage of our gene expert platforms, and now recently introducing the digital test X-rays so that then we can strengthen TB screening among persons living with HIV and AIDS and diagnosis for those that may have signs and symptoms. And then when it comes to treatment, one of the things that we do is at the point when treatment guidelines are being developed, the two teams work very closely to make sure that all the issues around drug-to-drug interactions and all the other comorbidity issues then are addressed jointly, so that at the end of the day, the TB treatment guidelines also include how to manage patients with TB-HIV co-infection and vice versa, the HIV guidelines. Then when it comes to prevention, like I mentioned, persons living with HIV AIDS, if they do not have TB, then they are put on TB preventive therapy. One of the things now we're seeking to strengthen is to ensure that they are able to complete their preventive therapy. Then the other thing that we have done is, for example, in the current, when we're applying for Global Fund grants, one of the things that we do is we have a joint TB and HIV grant, meaning that the two teams, whereas we still have our respective program areas to prioritize, at one we still come together to say for TB and HIV, these are the joint priorities that we're looking at. And like the one we recently submitted yesterday, it was jointly done between TB and HIV. And then during that process now we also engage the civil societies and the communities. And the other thing is around malnutrition. It still becomes a big problem, especially for persons who are co-infected with both TB and HIV. And so that is one of the things that we're struggling with because of the inadequacy of the resources available. But then we're also saying that for the co-infected patients, one of the things that we do is make sure that even when it comes to the organization of the clinics and the drug collection dates, we make sure we factor in issues around infection prevention, so that at the end of the day, persons living with HIV and AIDS, because some of the times the clinics are together with TB and HIV, then we time them so that they will reduce the risk of TB transmission to the persons whose immunity is low. Then recently, as we were doing both the PEPFAR grant and the Global Fund grant, one of the things we are looking at is issues of advanced HIV disease, because we realize that the number one cause of mortality among people living with HIV and AIDS is TB. So it's one of those things that we cannot take off the table, because then we will reverse all the gains we have done or achieved when it comes to putting them on care and treatment. So the two programs work very closely together. From where I sit as a program, a lot of things keep me up at night, but it was to sort of prioritize them. One is the need to ensure that the new interventions are rapidly adopted and scaled up, because we see that as a ripe opportunity to scale up the quality of care for patients that have TB or presumptive for TB. And when we talk about new innovations, it's not just diagnosis but also treatment. We're also seeing a lot of new treatment innovations coming up. So being able to strengthen that. Then secondly, looking at, and allow me to give three. Then the second one I would say is the issue around management of malnutrition, especially among patients who have TB or even TB and HIV, because it's a big driver of mortality among our patients. And then the third one around leadership and governance and community engagement, because we realize that out there in the community, one of the reasons we're struggling with tuberculosis is stigma. And stigma is driven by the fact that people are embarrassed to talk about TB. It's not one of those diseases that people want to stand and talk about. Yet we have an opportunity, as we continue with community engagement, to invest in resources, to invest our resources in creating awareness and demand creation, even for some of the services that we're rolling out. So if I was to package, allow me to give one, those three would give me sleepless nights. Yeah.
I'd just like to put a historical reflection in. I'm sort of quite an old lady, and I can remember in the 1950s TB hospitals in the UK, and people were pushed in their beds outside because fresh air was deemed to be the treatment. And clearly we know that fresh air is wonderful, but it isn't the answer. And friends of contemporaries of mine at primary school had TB and were taken away from home, put into these hospitals. Very often they didn't survive because that isn't a treatment, that is just a way of isolation. And it's just marvellous to see that here you've actually completely broken all those barriers, and people are surviving. And surviving with a good quality of life, because that's important. Survival on its own isn't enough. You actually need the quality of life that goes with it. So well done.
Thank you. And I think related to that is now we've also realized that, especially for patients who come with severe pulmonary TB, one of the things they're suffering from is post-TB lung disability disease. And as a result, once they've been treated for TB, they have this residual damage to their lungs that makes their quality of life not really very, very good. So they're not able to resume their routine work and make a living out of their lives. And so one of the things that we're trying to see, and we have a small pilot we'll be doing through Global Fund support, is to see how we can leverage on community-based physiotherapy programs. So aerobic exercises out in the open fields to sort of help them to recover and regain their lung function as a way of helping them to come back to as normal quality of life as possible. Most of the donors look at the big three, TB, HIV, and malaria. But yet, a lot of, because of pollution and the kind of environment we're living in, because of smoke within the living quarters and treatment, the kind of energy that people are using, lung health issues are actually something that is big, but we are yet to quantify because we can't even diagnose it in the first place. So one of the things that the program is also advocating, and we are trying to leverage on the TB program, is making sure that, for example, some of the AI solutions that we are adopting don't just help us to pick TB. Can they help us to quantify the magnitude of these other chronic lung conditions and post-TB lung conditions, and then from there be able to build it up. So
has Kenya had issues getting access to bedaquiline? Bedaquiline is a shorter, more effective drug regimen for treating MDR TB, multi-drug resistant TB, and Johnson & Johnson hold the patent, and it's just come to the end of its patent life, but they are prevaricating in a way that it looks like it might be made difficult to access these drugs further in the future. They're really expensive, but they're really effective, and so we have difficulty getting them in the UK. So I was just curious.
Burden countries, we still consider our MDR burden still significant, with over 700 patients being notified every year, and the number is grows. However, we've had issues around, first and foremost, access to diagnostics because of erratic supply of commodities. Again, sometimes the commodities, COVID Delta is a big one, the suppliers were not able to sustain the pipeline and the demands, but that is slowly picking up, and as that picks up, we're also seeing a surge in the numbers that we're likely to be notifying. Now, when it comes to treatment for MDR TB, one of the things that we have considered is to first move away from the injectable regimens and we moved to the all-oral regimen, but it's still very long because it's up to 18 months. And therefore, recently we've begun discussions as a country to transition to using the shorter-term 6-month regimen, and that is the BPAL and the BPAL. And with that, bedaquiline becomes a critical component of that treatment regimen. Now, so far, while the patent is still there, we've been accessing bedaquiline. But then we've already had engagement with civil society. They have actually raised that as a potential area of concern, and it's discussions that are ongoing. How can we then as a country put in our voice to be able to advocate to make sure that countries are allowed to be able to access cheaper alternatives for bedaquiline that are also how would I say it? They've received the requisite approvals. So they're good quality but cheaper alternatives to the expensive options that will be out there. So I would say that's a conversation with the civil society, and that's why I said one of the things that we're really grateful for is a civil society that is very engaging. So anytime such issues come up, then they bring them to the table, and as we speak, there's an ongoing discussion around that. And we hope it will be successful.
Yeah.
In terms of leading causes of death at national level, I would have to reconfirm the numbers. The diseases in those priorities keep shifting every year. But at least from the last ICD, the report that we had, one of the leading causes of death are infectious diseases. And we're also seeing an increase in non-communicable diseases being a big driver of morbidity and mortality, and cancers are also emerging as a threat for morbidity and mortality. But I would have to confirm actually the actual numbers from the last report. But yes, those are some of the infectious diseases, both for adults and children, respiratory, gastroenterological, and other infectious diseases, malaria.
So TB is taken out of infectious diseases?
Yes.
Yes.
Yeah. And then now we're looking at other factors such as cancers, comorbidities like non-communicable diseases. Then now lower down the line we also have things like road traffic accidents and the rest.
Is there anything that we can do to help shift that conversation and shift the approach to, and not just necessarily for research and development, but also for kind of the manufacture of drugs, the research and development of drugs, and then the distribution of them?
Okay. Yes, so there is a lot that can be done. First and foremost is to be able to create top-level advocacy for some of those processes, and especially looking at the manufacturing component. One is because the market is not so large. So most of the manufacturers struggle because of the amount of market, the size of the market that they have to feed into. However, we have opportunities by looking at regional blocks or regional manufacturing opportunities, so that then advocacy and engagement happens right at that regional level. So regional organizations like the African Union being able to advocate and drive some of these conversations, so that as they're looking to strengthen local manufacturing, then it's not just based within a country, but we're looking at the region. Secondly, the other struggle that manufacturers face is issue of financing, because a lot of them would want to be able to do that, but they need money first, to scope the market, 2, to invest in the actual manufacturing, 3, to have demand, to drive for demand. And therefore, being able to access loans is not something that organizations or institutions within the developing countries are able to access. Then the third thing is the prohibitive environment of the tax regimes within the countries that they are working. So you find that because of the tax implications, it's actually cheaper for countries to import most of their commodities, both treatment and vaccines. The other day I was looking, and up to 99% of our vaccines are imported. Yet during COVID, we realized that the developing nations were able to step up and start developing generics. So the capacity is there. So just investing in them to build their capacity to provide a favorable manufacturing and financial and policy environment to be able to allow that. Then the other hurdle that these organizations will face is issues around registration and patents. So you find for them to reach the quality, and I'm not even saying they should have lower quality, but the stringent processes of getting those approvals are so prohibitive for most of them. So if there can be a way of facilitating that, that would be useful. But then also in country, a lot of good work is going on, a lot of data is being collected as to what kind of research, what kind of treatments are actually required or most useful. But countries do not have in-country capacity to package that into information that can be used to inform decision making.
So I've visited African countries before, and as a result of that I've then raised issues in Parliament, whether it's through written parliamentary questions or verbal ones, and held debates. And that's one way we can influence government policy through the Foreign and Commonwealth and Development Office. So what more could I do to get that message across of what you need? So we talked about the R&D side, which obviously is going through the research institutions, but from a government policy point of view, what would you want me to raise?
From a government and parliament, I think 2. 1, around the same research and manufacturing, just pushing for a strong or a facilitative tax environment that can provide incentives for manufacturers, and including government financing for some of these initiatives. Then secondly, when it comes to some of the activities that are around TB treatment, and we realize that the adoption of new technologies and all the other activities that we are calling for calls for a lot of resources. Now, there are a lot of innovative financing models that are coming up, and for example, one of the things that we've recently looked at is the issue around converting some of the loans that countries have taken so that paybacks can be translated into investments for health, and TB sort of trying to leverage on that. So if at the point when these concessions with other governments are being entered into, that conversation can be brought to the table that yes, we are willing, for example, as World Bank or IMF or whoever, we are giving you this money, but your repayment modality, then we can be willing to reconsider your interests if then those can be plowed back into health, or instead of paying them back, can you increase your investments to the health sector? So some of those innovative financing options are things that can be driven at parliamentary level. And one of the things we have done following the African Members of Parliament Summit, that has already been brought to the attention of our members of parliament, and we are saying, as you engage in government, then can we start having conversations towards using some of the available financing options to be able to convert some of that loan repayment and interests into investments for health. And then now making sure that as that decision is being made, TB becomes a priority. The other thing that members of parliament can do is advocate for ring fencing of resources. Now we realize that governments do allocate resources for TB and all these other health priorities, but every time there are shocks in the system, every time there is a need to withdraw money and invest it elsewhere, it's very quick money. That money for health that was to be spent for medicine, we can use it, and then later on we will look. By the time we go back, probably the money is no longer there or something like that. So if there could be policies around ring fencing of resources, even domestic resources for health, so that then we have sustainability in terms of commodity supplies and making sure that we don't have unwarranted shocks in the system that then set us back in our TB control efforts. That would be something that Parliament can really do for us.
Thank you very much, Dr. One of the things that we looked before is when you look at that for health is the ability and to accurately monitor so that then you can go back to allow that to see, yes, the dollar was used for with the format of this. What's your opinion on how that can be strengthened? Because when we are looking at global fund and a few others, that has been one of the things like talking to the treasury with this dollar and give me the money to provide nutrition for that kind of stuff and guarantee whoever gives the money that with this investment we not sell the dollar, but when they have double impact here, that we don't have to look for the dollar. You see, use the same Kenyan shilling, and then the same Kenyan shilling is now used to acquire on the health of our people. But that kind of modality, has that happened? Do you think it's something that can be done? And how do we get that political goodwill?
So there are two things. One, there's the issue of at the point when we receive resources, any resources that we receive for implementation of activities, one of the things that we do very early on before starting to implement is to have a robust monitoring plan, not just for the activities, but also for the expenditure, so that we're able to track, one, are these resources being used for whatever purposes they have been intended for. And one of the things that we're also trying to incorporate in that is an element of community-led monitoring, so that at the end of the day, then we are not the only ones policing ourselves and saying we did what we pledged to do, but we also have the beneficiaries adding their voice and saying, indeed, those services reached down to us, and they were to the level to which the program actually commits. So that's one element of it. And when it comes to monitoring, we are looking at the services, but now at our level we are also looking at the investments. But then secondly, related to that is making sure that as we are planning, because as I said, we have resources that are coming in from multiple streams or multiple sources, and you find sometimes there is a risk of duplication and a list of efforts being two different organizations actually investing towards the same opportunity or activity. What we do is we do what we call joint planning. So for us as a program, because we know we have many donors and many investors seeking to support the program, when we're doing our work plan, we do it jointly with all of them. So we put all the resource envelopes on the table. We look at what are the program priorities and then allow the different investors to identify where they're plugging in. So at any one point, the right hand knows what the left hand is doing. And we're also very clear on what gap the government resources are also filling, so that at the end of the day, that removes any component of duplication when it comes to the use of the funds. And then now at the point where now we're giving accountability, one of the things that we have ensured to do is the issue of making sure that the absorption rates are matching to what was already envisioned earlier. And one of the things, and related to what she asked us to what members of parliament can do, is to some of the delays we see in implementation of activities is because of restrictive policies and the need to shift policies. And therefore, at that point, then we engage parliament to be able to shift some of those policies to provide a facilitative environment. And a good example is, for example, if we need changes in the social health insurance. It's one of those things that was available to support our TB clients, but because of the way the current health insurance scheme is structured, then we were experiencing delays. So we engaged the insurance provider, but then because of the parliamentary acts, then there are certain things they could change, so we go back to parliament and say, okay, can we then have this considered for us so that then the amendments can be facilitated for us? So in so doing, we make sure that one, we utilize all our resources, two, we ensure accountability, and three, we make sure that at least none of those resources go to waste or are left unutilized at the table.
I think as our elected representatives, then that's one thing one can be able to negotiate. From the other side, negotiate for us, then negotiate the other side. On the other side, when you meet our members here, is how that can be a collaborative activity among we as members of parliament. Because we as technicians can't give what Dr. have said, but we also want a support team from, at that level. And that will help us move, because we know the powers vested in members of parliament, and where we can provide the data, like you said, and help us. I think that will be very helpful. So like you ask, what is one thing that you can talk about? That's one thing that we can rely on Dr. Kaduri and say, guarantee me that TB will move to this way. On coordination, this kind of money is made available. Have that happened before? We talked about Gafi. And one thing that we knew, I'm sure you know that Tabu is one of those things we went in, Parliament gave him 750 million that was missing. And as a result, we have moved quite well in terms of the coverage. And therefore, a win-win situation where the head of programs of the technical bench does their job, but guaranteed of the resources. And then, bottom line, that every related community members actually benefit. And we have seen that happening. So it becomes very, very helpful. And like you said, also the sectoral approach where we are looking for that, I think the chief gave space, free 2 days in a week, so they didn't need to defer to build anything. And we have seen that in the Red Corner, where KJS and a few others. So I think that could be one way that we can actually push for when we have very well defined gaps, and which we can, with this kind of resources out there. The reason why we are hosting them is because there is a group called Action Globally. Action Globally is a group of 15 different organizations from different continents. That is actual members and results, where we look at global health generally, and therefore that includes the UK, where they are coming from, Canada, we have another region from Canada, the US, France, Japan, Australia, India, South Africa, and Kenya, Zambia, West Africa, as was before. Mid-15?
South Korea.
Oh, so,
Yeah.
that's right.
South Korea.
Yeah. And the longer the list becomes, yeah. But basically, it's a global team that works with the global health institution, that is the World Bank, the Bill Beatrice, and also Global Fund, and all that. I want to say UK, through the support of elected member of Parliament, is one of the few best supporters of Global Fund. And therefore, when the Democrat tells us this house is put by Global Fund, there is a better their contribution. And once all the way at the global level, how that thing is, the process is coordinated. So I think that I want to say, there's a short brief I want to say, and again on behalf of Civil Stand and specifically Kanco, we are very happy to collaborate with your team. And these have been a bit of time. I'm also, I used to work for government, so these places have been left government a while ago, and therefore also I can also say that I'm also part of the Ministry of Health.